Welcome, everybody. My name is Lita Haddon, the Lifestyle Coordinator here at Outlook Club in Summerlin, Las Vegas, Nevada. Welcome, everyone who's watching. Please, on the type area, if you could let us know where you're at, what your name is. If you have any specific questions, please type them in, and then I will ask Dr. Poelstra here any specific questions you have. We have Erica Nansen here from Southern Hills Hospital that she'd like to introduce herself.
Good afternoon. My name is Erica Nansen, Director of Volunteer Services and Community Outreach at Southern Hills Hospital. Today we have special guest Dr. Cornelis Poelstra here with us. He is a world-renowned spine surgeon and has performed more than 750 cases thus far, more than any other spine surgeon in the world. So he is definitely an expert in his field. I just want to thank you guys for coming. And if you have any questions, like Lita said during the presentation, please let us know. Enjoy the lecture.
Very good. Well, thank you very much for the introduction, and thank you very much for your attention. From what I understood, not just in Vegas, but all the way up to North Carolina and Florida and so on. So I'm excited to be here with you. I'm very appreciative for the people that are here. You can't see them on camera, but we have very nicely separated a few spectators here locally, and they will be able to ask questions by raising their hand, and I would invite you to write any of your questions down in the chat box, and then hopefully together we can start fending those off. So the topic for today is robotic spine surgery. It's a very exciting field, and as Erica said, I have been very fortunate to be part of the initial development with the robotic system that I'm going to speak to you about. I'll show you some videos of cases we're doing. And I also want to teach you something very important about standing up straight and your balance and all kinds of things. And we'll try to make it somewhat entertaining and maybe, sort of a dialogue with the questions that come in. So my name is Cornelis Poelstra. I'm an orthopedic and neurological spine surgeon. So I did training in both. I'm orthopedically boarded, but I'm happy to answer any questions both ways. And it's pertaining to the spine, so I'm not a brain surgeon, but I've done the neurological spine fellowship also. And what we're going to talk about is the robot that you see depicted here. We're a trilogy today, and I just recently came here out of initially up and down the East Coast, then Florida, as you'll see in a minute. I was for a very short period of time in Silicon Valley building on some newer projects, and then just recently moved here to join Dr. Grover at Allegiant Spine, the Nevada Spine Clinic, and we have set up the Robotic Spine Institute of Las Vegas because, again, I have more experience than anybody else in the world doing robotic surgery, and we want to bring that to the patients here, and hopefully for maybe some of you that want to travel here, we take care of a lot of national and international patients also. So without further ado, this is a little bit about me, as you can hear, from my not so much southern twang from Florida, but I have a little bit of an accent, obviously. So I did medical school in the Netherlands, and eventually after graduating from the university there, I did a PhD in collaboration with a research institute in Northern Virginia. And as most of us, right, we come over for 6 months. It resulted in 2 years, and then I sort of stayed here. I did my orthopedic residency in Charlottesville, Virginia, one of the top 10 programs in the country, got a wonderful orthopedic training, and then completed my neurosurgery and spine fellowship training in Philadelphia at the Rothman Institute. It's inarguably the #1 training center in the world for spine surgery. So I was very fortunate, especially as a foreigner, to get that opportunity. It's at Thomas Jefferson University, smack in the middle of Philadelphia, and then I moved to Baltimore at Shock Trauma. Shock Trauma is the world's largest spine trauma facility. It's a 1,600-bed hospital system, and I worked there for 4 years and really honed my skills doing very difficult things, right? People come in 2 pieces, and we put them back together, and they live there. Absolutely unbelievable experience, and that set me up for my move then to Florida. So I worked in Northwest Florida in Destin, that some of you might know as a beautiful vacation destination, and took care of people from about 4 hours or so around there, because there's no university nearby, and there's a lot of people that had a lot of degenerative deformity issues, and those are difficult cases, and most of the local surgeons that were there had a hard time dealing with these difficult scenarios. So it was a lot of people that came to me from that area. So we really set up a complex spine center in a very small hospital. It was right here on the Emerald Coast in Destin, close to Pensacola. As some of you guys may know, it was a robotic surgery and a development site for the robot we're going to speak of. It was truly academic spine in like a private practice setting. So it's the best of both worlds, right? I mean, the surgeon's taking care of everything, but you still get academic level spine care. So we were very successful there, and then transitioned to Silicon Valley for a short stint to develop some additional robotic technologies until I settled here about a month ago at Allegiant Spine with Dr. Grover just now. And we have this Nevada Spine Center and the Robotic Spine Institute of Las Vegas. These are some of the cases that you know are fearful. You know, you hopefully never ever have to do any of this, right, to a patient. And as you patients, hopefully will never have to have anything of this done. But if it's necessary, you want to have somebody who's good at this, who does this a lot, and who, you know, has maybe technology to make this more predictable, more precise, and more repeatable, reproducible over time. So these are some of my, you know, more complex constructs that hopefully none of you might need. But in addition to a spine surgeon, I'm also, you know, a doctor who cares about his patients. So I just got COVID vaccinated last week. I feel great. So all I can do is encourage you to do so. I don't know about conspiracy theories and those kinds of things. I think we have to be less worried about that than just making sure that we get safely through this winter and on to a better 2021. So I would encourage you to do the same thing. So what do we as spine surgeons do, right? We really take very good care of patients with all kinds of problems. So most of the things that we have in our clinic are fairly straightforward. Sometimes we have very complex things, but most of these things get taken care of through conservative care, right? When you come to me or any of my colleagues, we're not ready with the scalpel to cut you in half and put you back together, right? Don't be fearful of that. I think it's good to have a surgeon with the clinical acumen of, you know what, this deserves potentially an operation versus, you know what, these are the evidence-based things we can do to make you better. I think it's good to come see somebody with spine problems and not just rely on only conservative physicians who can only do things with, say, manipulation or injections and so on, because they will never advise you potentially to something that could really help you, because that means that you're out of their practice, right? We're happy to do anything and everything. We work together with the pain management guys in our practice. We have physical therapy, chiropractic, everything's there. And that's why I came to this practice, because I think this well-rounded practice that can provide everything from A to Z, including potentially the most complex things, will give you the most honest answer about what you potentially could have done. So if we do surgery, sometimes we make really small poke holes, right? We do little camera surgery to your spine. As you can see here, we make incisions no bigger than a dime for these kinds of you know, smaller type problems should you need an operation. And some of you may remember like the Laser Spine Institute. There was a lot of marketing, but it sort of made sense, right? They took care of relatively smaller problems through smaller incisions, and they were able to do this in high volume. So during the time when they were successful, they sort of reproducibly were able to do this, but they only sort of stopped at those procedures. Of course, they did not do scoliosis corrections and those kinds of things. If small things don't work, right, sometimes alternatives have to be considered, and those are sometimes bigger type surgeries, and that's where robots come into play. So what I'm going to present to you is mostly, you know, things with hardware and rods and screws and all these kinds of things, as well as that I'm going to teach you some things about why we do it. But don't think that we don't do also these small operations, right? In one day, I might do, you know, 2 complex things, but we do 3 small things too. Little micro discectomies, a little endoscopic, that's with a little camera, removal of some pressure of a nerve that was given people maybe some sciatica complaints, right? Simple things. So it's not that everything that I present here is what we do all the time because we so badly want to put rods and screws into everybody who's alive. But if we talk about robots, we're talking about, you know, drills and drivers and those kinds of things. And we talk about reconstructive type surgery. The robot we're going to talk about is called the Mazor X, M-A-Z-O-R, and then capital X. And it's a system that I'll describe to you with a bed-mounted robot and an enabling computer that allows us to basically virtually do your surgery before the case. And then we have a very intelligent camera that looks down onto the field that can show us exactly where our instruments are at any given time that we utilize through the robot. So it's not like when we do robotic surgery that I just give the robot to go ahead and I sit in the corner and do nothing, right? We are actively involved, where the robot guides us during surgery to a path that we have created, usually the night before, sometimes the week before, depending on the complexity of your surgery. So what this is all about is this spinal hardware, right? We're putting in rods and screws. And to be honest, even when I trained like 15, 20 years ago, that was the big deal because it took so much stress and skill to put in screws and rods in a patient that we almost lost all of our stress and the ability to do stuff during surgery already where the hardware had to be placed. However, but all the other things during surgery are far more important. The exposure of your spine, doing proper closure, get the pressure of the nerves, maybe work through scar tissue, and all these things are still just a skill. It's a craftsman type work, right? But we had to utilize all of our stress already to place the hardware, and we could potentially be better at this, but our attention and focus all went to those rods and screws. So the idea was that if we make the rods and screws easier, then we actually become better surgeons at all that other stuff. And I'm going to show you that we were capable of doing that and actually show that through a bunch of research as soon as we had a robot. Because what does the robot do? It makes the hardware much more safe and it makes it more have a greater efficacy. So we can do a lot more in a shorter period of time while it takes less stress from us as a surgeon. So we do the right thing for each specific problem and the robot guides us to do it in a more predictable way. So we allow evidence, right? We do evidence-based medicine. We allow evidence now with the robot to show us that we are actually better surgeons. Not so much because the robot arm is this cool thing that we have in the operating room that helps us to place screws, but more because it takes away a lot of stress from us, from that component of surgery. So we're better at other things, as well as that we are much better prepared because we virtually do your surgery the evening before, the week before, on a computer system. Your whole surgery is planned, and then the robot helps us execute it in a stepwise fashion, and I'll show you how that works. So since November, I'm here, the Robotics Spine Institute of Las Vegas, and the website and so on. You can look all this up, and very soon we'll have a bunch of cases and so on over there. It's within Allegiance Spine, the Nevada Spine Center, and of course, we have this at Southern Hills, and I'm very proud to say that I'm part of the hospital there. Has a tremendous reputation, great quality of care, wonderful people that I've met, as well as that they have the right mind, right? It's not that, the status quo today works well, so we close our eyes for other and new technology. They very carefully vetted what I proposed to them. And they said, you know what, yes, this makes perfect sense, again, based on the evidence that we have proven already that we're better utilizing modern and exciting technology. So we have the robot since about 2 weeks. We're training everybody now, and I'll hopefully spearhead that thing since I've done more than anybody else in the world, and we'll help the teams to get up to par, and I can't wait to get that started. So to talk about where we start, right, we always have to look at our history a little bit. Where do we come from? Because I think it's humbling to think, what, we didn't start out of the gate with suddenly a working robot, right? For a long time, we did open spine surgery, and if you needed an operation, you got a big incision. And we were really good at this, even in complex cases. It may take, between 8 and 14 hours to do those surgeries, but we were able to do it because nowadays, I mean, look at Trilogy, right? The new 60 is like the past, or the new 80 is the past 60, right? People want to be active. I see people here, honestly, there was an 83-year-old lady on the Peloton, and she was just cranking it out. I'm very impressed with that. And I think we can't close our eyes for the fact that society has changed, we have evolved, we live longer, and we live healthier during our younger years, so we can benefit from a greater health when we're older. And these communities are a prime example of that. So I'm excited to speak to people that sort of think similarly, right? Otherwise, you wouldn't be in this community, because I want to keep you going for as long as possible. But we can't close our eyes for the fact that things start to wear out. No matter how active you want to be, at some point, the biology can't keep up with aging, and it's like gray hair and wrinkles. And at some point, biologically, you might still feel you can do stuff, but your joints and your spine don't want to do it anymore. You have some nerve compression, and you just really can't. So then it's probably better to get that fixed so you can get back on the Peloton or go walking or whatever you're desiring to do, as opposed to sitting and be like, well, I don't want to go operation because this, that, and the other. Sitting is bad for you, right? Motion is lotion. So being up and around, and even having, if you have a curve of your spine that doesn't allow you to do certain things anymore, have us help you fix that, will give you a much greater quality of life if the indication was appropriate and the surgery and so on went well. Then you're going to do a lot better afterwards than just sitting and feeling sorry for yourself because your leg doesn't work so well anymore. So don't be scared of talking to us about things, right? So this is a fairly straightforward connection here from the left to the right picture here. This is a revision type operation in a very elderly female, and you can see there's lots of connectors and other things that we had to do over and over again. But what I wanted to share with you is that the way to get there, unfortunately this is sort of far enough away to not have too much detail, this is the incision that's necessary and the retractors in there to get that surgery done the olden ways. So we used to make an incision and have the size of about a very large salad bowl open in the operating room for a prolonged period of time. And unfortunately, we were still able to do a really good operation through that, but the side effect of a big incision and a lot of soft tissue exposure is not good for you, because it can lead to very bad wound breakdown, it can lead to infections, and of course it leads to an inflammatory response in your body that you have to get over that is much worse than just the spinal reconstruction alone. So that's why we sometimes say, well, it takes 8 to 12 months to get all the way better. We've shortened that at least by about 75%, doing that now with robotically guided procedures by making small poke holes and not making these big incisions anymore. Still, the surgery and the reconstruction is just as good, if not better, but the toxic effect of the surgery is much reduced by the way that we approach these problems nowadays. And why is that? Well, exposure and closure, like opening up, seeing the spine, and then closing it up afterwards, takes a significant amount of time. It's very inefficient. There's a lot of infection risks having these wounds open, so we should not ignore that. There's a lot of inefficiency in this, right? If you would be able, with X-ray or some other modality, be able to see the spine underneath the skin already, why would you have to make a big hole and peel all the soft tissue and the functional muscles off to be able to do your surgery? Reproducibility is an issue, right? There's a lot of these cases that get done in teaching centers because they're complicated. And if you have, a tired resident or the second-year medical student, which, I don't feel bad talking about it because I was that at some point too, and you try your best, but you just don't know, right? So the reproducibility from center to center is potentially an issue. And then there's accuracy issues. If you're tired and it's Friday night and it's 9 p.m. and you worked all week and then you have another call case, I mean, honestly, even in my hands, I might not be as good as I was on Monday morning, starting fresh at like 7:30 in the morning. So if we used to, fix these problems, so this is somebody who can't stand up straight, right? That's the side view of the spine. This is a spine with a very bad curve that sort of hides in this stuff over here. This patient had a pain pump placed already. She can't stand up straight to save her life. If we used to do these cases open, and I will save you the pictures, the data we had showed that we had at least a 29% complication rate, maybe even in the next paper, we had, come on, a 39% complication rate when the cases got even more difficult and the patient got a little bit sicker. And it was up to 42% with we call this the International Spine Study Group, where we put our heads together who do these kinds of cases and look at, what is truly the outcome, the success or the complexity and the complications associated with these procedures. And they're not to be ignored, right? So then we said, in 2005, I was at shock trauma, and we said, if these trauma patients we have, if they had to have a spine operation, but we were able to make it a little bit less toxic for them, since they're fighting off this trauma already with broken arms and legs and so on, intra-abdominal trauma, and then we hit them with a hard spine operation, they actually get from that second hit so much extra damage that in some cases they didn't make it despite of our best efforts, right? So we said, can we do something specifically to this group that's in dire straits in a more minimally invasive fashion? So we started to do this. Why? Well, because we said, it's better for patients, right? If we don't give them a second trauma by operating on them. If we minimize our surgical trauma, they can heal from the original trauma that's bad enough and maybe still have a good operation and safely get through it. So we said, if we lessen comorbidities, like that's the bad things that come from surgery, we shorten our OR time. This is part of this minimally invasive pathway. We reduce radiation, both to the patient as well as to us, me and my team, right? Because we're constantly surrounded by radiation. So the less is more. We want to have obviously fewer complications so people don't have to come back to the operating room. We certainly don't want to have to re-operate on them for any reason, like misplaced screws or other bad things. And if we planned our surgery, we probably would be better off than just coming to the operating room and sort of MacGyvering it up, because that's what part of this was, right? New implants came out, so we sort of MacGyvered stuff together and then figured out what was better and then did the next best thing. If we planned things better, we'd probably be much better to achieve all of this. So everybody agreed with this, right? All these meetings that we went to. So how do we accomplish that together? Then we said, you know what? Let's start with doing minimally invasive hardware placement and have wires in place as opposed to making big incisions. So here you can see very complex surgeries that are being done, and we were able to guide wires into the patient, and the screws we use are cannulated, so then we slide the screw over the wire, and we can place the screw without actually looking at the spine, since we use X-ray to visualize things. So this was our first attempt, and we were pretty good. This was complicated, right? We had lots of things sticking out of the patient, and we had to whittle a rod underneath and all this. So this required better skills, different skills from us, but we were able to do this. And we felt this was applicable for everybody, but the reproducibility of doing this with just X-ray is hard, because you have to be really dedicated and you have to have good hands, and it wasn't for everybody. So putting screws in here that you fire across the spinal canal and then imagining putting a rod in between all of this was difficult. So we started with sort of what we call onesies and twosies, single, maybe two-level surgeries. And the way we did it was with what we call percutaneous hardware, percutaneous screws, and we used X-ray. So this is called a C-arm because it has a C shape, right? There's an X-ray machine at the bottom here that generates X-ray, and this is called an image intensifier. So the X-ray beam travels through the patient's body, and then the image intensifier here creates a picture for us. And we can sort of navigate without making incisions in the skin, still using X-ray, but we can navigate down to the spine. And the way we did it, we drew lines on the patient. We had to make sure that the angle of the machine was correct and all that. And this was like, early 2000s when we started doing this. And for single level cases, it was easy. For multi-level cases, we did the same thing. But if you do an 8-level case here, it might take 4 minutes of fluoroscopy, meaning 4 minutes of X-ray. And 1 minute of X-ray with that machine equates to 250 chest X-rays. So imagine if I did 4 minutes of fluoroscopy with that machine, we virtually took 1,000 chest X-rays of that patient, as well as of me and my team, like multiple times a week. So in theory, this worked. Practically, it worked, but the X-ray requirements were way too much. So we started doing this initially with shielding ourselves and so on, and then we had patients come in with problems like this. So you can clearly see, bad motorcycle wreck, and you can see what that spine looks like. So instead of making these massive incisions, we did things through poke holes, and these were the initial systems that we developed to be able to work down to the spine. And suddenly we didn't have to make large incisions anymore. We had like no blood loss from it, and we were able to fix these things really, really well. And this is a classic example of one of the longest cases that has been done, that I've done in the world. So this is a patient who has a spine that's really stiff. It's almost like a piece of chalk. There are diseases that do this to people. So you lose all flexibility, and the bone sort of grows together almost like a bamboo spine. Now you can imagine if you get hit and you have a flexible spine, your spine is able to absorb that a little bit as a chain. Unfortunately, if your spine is like a piece of chalk, it actually breaks like a piece of chalk. So it snaps basically all the way across, and the only thing that is in continuity is your spinal cord, but your bony stability around it is completely fractured. So you see a crack right here, as well as a crack right here. So this piece of chalk is like floating in between two other pieces of chalk. And we know from the literature that if you have an injury like this and you have to be even positioned on the table, on the operating room table, you have a 50% risk of getting paralyzed. And the reason is that this chalk just doesn't align very well up, especially if you get turned onto the operating room table. And the only thing that's connecting in between is the spinal cord. So these are highly, what we call unstable injuries. So they need to have surgery, these patients, otherwise they can't sit up. They can't go to the CT scanner. You can't do anything with them. And this is sort of this damage control type surgery, because this man also had an open brain injury. So you can see his head over there. He had his left arm crushed because he was hit from an SUV from the left side. His left leg was also crushed because he was hit from that side with the SUV. He had diabetes already, so he had high sugars. He had high blood pressure, so he was an unhealthy gentleman on lots of medication. He was 268 pounds. So patients come with these comorbidities too, right? In addition to the problem they may have. And then if you look here, all of the ribs on the left side of his body were crushed. So they were all fractured, all 12 of them. And there's all this blood that is sort of extravasated out of it. So this man is in extremis, right? Very, very sick, needs to be resuscitated, needs to have his spine fixed. but the risk is very high that if we don't do that early and he gets moved around from bed to bed, or he has to move his sheets and stuff like that underneath him, right, with the nursing staff, that these people get paralyzed. So this was the longest case that we've done. So this is from high up in the thoracic spine, all the way up high, all the way down to his lumbar spine to stabilize these highly unstable fractures. And again, this is 2 hours of surgery, which used to be like 8, right? It's no incisions, it's no blood loss. It is very, very straightforward to do this technically, but again, 4 minutes of fluoroscopy, 1,000 chest x-rays. So this turned out what the general trauma surgeons told us. I mean, these are like life-saving operations. We were never able to save these people because they either became paralyzed or they died. And in this case, we got these people through it. They lived, and they didn't get paralyzed, but we had way too much radiation on board. So then what we started to think is, how can we maybe see our instruments without all that radiation? So that's called navigation. So you can look this up if you want to make some notes maybe, and later on look at this. So this is basically what we call computer-assisted surgery. There is a way to identify where your instruments are in space, and the neurosurgeons, the ENT surgeons, and the orthopedic surgeons learned to use this. And the way that this works, you can see this a little bit behind me here. There are some cameras there that we still use, but now we have better tools to guide our instruments, and we don't just rely on the navigation alone. There is a very well-known system. It's called the Stealth Station. So this was called stealth surgery, and it started in 1995. I did in Virginia surgery with it in 1999 already. We put pelvises and so on together, and then the system went through lots of iterations and development until now being pretty slick and utilizing very, very little x-ray. So this was the navigation side. This was the visualization side, but you still had to do surgery. And how did this work? You had tools that had these, we call them fiducials on there. So they're little reflective balls. And you put one of these markers on the patient with these reflective balls. And then if the infrared camera would look at it, it knew relative to this frame on the patient, it knew where your instruments were. And with just a couple x-rays in the operating room, once you knew where the spine was, you could move these tools in space and follow them on a screen. So you did not have to have constant updates in your x-ray, since the x-ray picture stayed the same, but your instruments were able to be tracked in space. The downside was this camera thing needs to have a perfect line of sight of your field, because as soon as these reflective balls weren't seen by the camera, you lost where your instruments were. You were basically just going blind, right? So this makes it kind of hard if you constantly have to keep your hands out of the way of parts of your surgical field. And you see me doing this here. See, this is my reflective ball. So I'm hammering something in the patient, and I'm looking up at a screen. So that was the other downside. You had to look at a TV monitor while you move these instruments around to make sure that you knew where they were going, and they pierced perfectly through the bony column that you got into. So it worked, but it wasn't really perfect yet, because we had to divert our attention to a monitor far away. And to show you what that sort of looks like, this is a couple of colleagues of mine operating, and look at this. If my mom would be down here and they have all their instruments and all that kind of stuff, and they would purely be diverting their attention away, I think that's still not ideal, right? I like to look at what I'm doing. I used to be a car mechanic for 9 years. So I used to look at what I wanted to do, and then I could accomplish pretty much anything and everything. But looking away requires some additional hand-eye coordination. Now, some of us are better at that than others. If you're good with the Wii and you can play, from the olden days, right? You could play Frogger and Pac-Man really well. It turned out you were pretty good at this too. But that's not for everybody, this hand-eye coordination thing. So if you look at the impact of this, though, initially, so these are not so great pedicle screw placement, these screws that we're talking about, to really good ones. Over time, with these, what we call enabling technologies, a little bit of x-ray and a lot more of this navigation type stuff, we got better and better and achieved very, very high percentages of success of our surgeries. But what I said earlier, right, it's still like craftsman surgery. You have to sort of look at a space, and then in 3D, with 6 degrees of freedom, you have to sort of figure out where your hands need to be in space, while you can't even look down at them. So this requires sort of this disconnect. People that play pickleball really well are good at this too. So we said, you know what, since this works, but it's not reproducible, how can we make it more reproducible? Because navigation alone in the operating room, these little fiducial balls, right? It's like autopilot, but if your pilot is this guy, I'm not sure how excited you would be to get on a helicopter with him, right? Despite all the technology that's available, since he has to still follow that line. So since we all knew where we wanted to go, right, how are we going to get there next? So we're talking now, this is 2008, 2009 or so. So this is about 10, 12 years ago. So we started to look around ourselves at that point. And that's how we came up with, what does minimally invasive spine surgery look like in 2030, right? Where do we need to go? What's the long-term vision? And then we started to look around, and then, look what everybody has, right? If you look at a catalog nowadays, back then it was like the sharper image catalog in the plane, right? Had like all these like interesting like robot type things. Now it's all the way, everywhere on the internet. If you look at Amazon, I mean, the first page you see, it's like, if you buy something for your kids or your grandkids, it's all robotically driven. It has all smart technology inside. I was in Fort Walton Beach and Destin, right? So this is how the colleagues across the water, were fighting off the bad guys. Anybody who drives a car knows that these things are being put together this way, right? There's very few people involved because the reproducibility, cost, and speed are just so much better with this. And I'm very fortunate. I teach in Asia a lot. So this is actually an Electrolux air conditioning facility. There's 2 buildings. They're exactly the same size. And each building, they make 3 million air conditioning units a year. In the building next door, they have a total of 3,000 employees. In this building, they have 4. So I'm not advocating, right, that we're displacing people and all that. But on the other hand, we can't close our eyes in medicine for what's happening in the world around us. That's what the point of this is. If you want to get a cup of coffee nowadays, robot cafes are everywhere, right? This is at the airport in San Jose, in Silicon Valley, all around. I mean, there's no baristas anymore. There's just robots that give you a perfect cup of coffee every single time. You know exactly what you're going to get. Some of you might know and have experienced the Da Vinci surgical system out of Sunnyvale. It's a wonderful system from Intuitive Surgical. But if you think about it, it's not a true robot per se, but it's a very fancy drone, because every step of the way, everything the robot does gets done by the surgeon in a console. So you basically have a very fancy remote. It's attached to your fingers, and your finger motion is mimicked by the small little tools on the inside of your belly in most cases, sometimes your chest. So they're very good at doing abdominal surgery, prostate surgery, some breast surgery, and then some heart surgery with it. So since it just shrinks down what your hands would be able to do. So these tools that are in here are less than 1/4 millimeter. And they're heavily articulating 6 different ways, right? And they have graspers and so on. And they basically mimic what your fingers normally can do. So very, very accurate, but different than the robot that we're going to talk about, because our robot does stuff by itself, as opposed to that you do it and the robot sort of mimics it. So we did feel that robots was going to bridge this gap of reproducibility. So this is me sitting with a bunch of robots. We were very fortunate in Destin to have, during this transformation, the support of the companies, and everybody was sort of seeing it. So my initial robots were all duct taped together. And eventually we came to, very slick looking devices that actually make things a lot better. And I'll show you some evidence why. What we tried to set out to do, though, in sort of summary, we minimized fluoroscopy or X-ray, right? Minimize all this radiation, maximize our efficiency, and what we want to do is reduce outliers. Cases that take too long, screws that are in the wrong place, these things on the outside of what we call a bell curve, right? If everybody works sort of in the center of a bell curve, so to speak, everybody's doing well. If you're on the outside, things are not so good, like 2 standard deviations away or so, right? If everybody drives in their lane, it's good. If you're halfway over in the other lane, bad things start to happen. So that's what we try to prevent with these robotic systems. Robotic accuracy initially very, very good. Initial phases we achieved 98.9 or better percentage of accuracy. So that wasn't the issue. And my transformation with this started about 6-7 years ago, right? When I started using these initial systems. I've done almost 1,000 cases now, more than anybody else in the world. And we started doing surgery with patients in the side position. So we didn't just have to put you what we call prone, like face down on the bed. We could keep people awake for this. And the current Mazor stealth system combines what I talked to you about, this navigation thing that allowed us to see, with the robotic guidance that helps us to get directly down to the spine. So it's sort of the best of both worlds that we currently have, and it's like the go-to system, and that's what we have at Southern Hills now. So why do I believe that this automation thing is going to be better and make a struggling surgeon better and a really good surgeon even faster and better? Well, because we have good evidence. I talked to you about before, right? There's no purpose in doing this unless we have evidence for it. Cool and sexy doesn't cut it, right, in medicine. So this is one of the early studies that we've done with 700 patients, 705 patients. 403 patients had robotic surgery. The 224 next patients had the original surgery where we used the X-ray guidance, and we did also 78 open surgeries. And without belaboring all the details, we'll go through this here. The risk of having a complication with the robot versus the original minimally invasive guide wire type surgery, the robot risk was threefold less than that group that we thought we were really good at, right, with X-ray and all this other kind of stuff. We already achieved early on a threefold less complication risk, same thing compared to the open surgery. But then more importantly, 2 years out, the robot achieved almost a fourfold lesser revision risk. So somehow we were so much better, not just in the operating room there, but also to address the pathology, that 2 years later, your risk of needing more surgery was fourfold less if we had the robot involved. And again, it has nothing to do with the robot arm or anything. It has to do with that we're better prepared and that we're not tired from just putting in the hardware. So we were much better at all the other things during surgery that makes your case a success versus, yeah, I had surgery and I'm still sort of the same, right? That's what we wanted to prevent. So fewer complications and revisions and about 80% radiation reduction already. So this was the first groups of patients that we went through. And then there was an additional study where we actually amplified this. It's called the refresh study because of what we tried to do with this. And the key to that study was what I want you to see here. This is called a survival curve. Well, this doesn't have to do with survival per se, but this has to do with the groups of patients that had yes or no complications. So what you see here on this bar is the number of days after surgery. And then here is the complication-free survival, if you will. So the top line here is separated from this line here where we used to do our fluoroscopic guided, like the X-ray machine surgery. Within the first 90 days is what this line means here. Within the first 90 days, there's the biggest difference because the robot group really had very few issues compared to the group that had the fluoroscopy. And after 90 days, these bars are basically, or these lines are pretty much parallel, right? So after the first 90 days, there's not much of a change anymore, but the initial issues that occur with sometimes spine surgery, like infections, wound breakdown, malplaced screws, like other things for which you may have to go back to the operating room, that's where the robot has its biggest impact. So we call in that group, when we look at the differences, from a 2% to a 20% complication risk. So it's like a log value difference. So we said, you know what, the greatest benefits of the robot during that surgery is that somehow we are better prepared, so we have greater precision, we have greater predictable outcomes in that 90-day window and simplicity of the surgery of that component. So we're better at the other things. And actually CMS, which is like Medicare, right, penalizes us as surgeons as well as hospitals for any complications within 90 days tremendously. So when we talk about the cost of robots, I go like, well, you know, a life saved, I mean, what's the price on that, right? But I mean, if you critically look at this, so you have hundreds of patients and you save a log value in complication risk to hospitals and surgeons from a payer standpoint, I mean, there's no excuse, right? How much better that actually is. So apart from that, how do we do the surgeries, right? We get a CT scan on you just before surgery. We approve the position that you're in surgery, and we identify the space that we're going to operate on, and in this case, this is the lumbar spine. Then from here, the robot actually clips the spine virtually in the individual vertebral bodies. You know, your spine is like set up out of all these different bones. And then these bones are being shown to us in a picture like this. This is called an axial image. So you can imagine this is a vertebral body. The spinal canal is here where the spinal cord runs. And then there are certain parts here where we are used to placing screws. So all that is still like the way we used to do it. But now we can plan all this virtually. So here is my planning picture. So I take the screw I want to put in there, and hopefully this is presenting that I can move that screw in and out. I can change the length, the diameter. I can look at it from multiple different ways. I have a 3D model that shows me what my final product was going to look like. I can put extensions on those screws, so I can even look where the skin incisions are going to be that I need to access the spine with this. Then I go to a picture here that shows me exactly what I would need. So the rods that are connecting the screws are displayed here. I know the length of them. I know exactly where the skin incisions are going to be. So the only thing that I sterilize and set up in the operating room are the tools that I need instead of all of these toolboxes and trays that we used to have. We used to drill a hole and then say, oh, I want to have 2-inch long, this, that, and the other, and then the tech in the back had to go look for it, and then there was a rep usually with a laser light who like shined on it and was like, you need this one, no, 2 over to the left. I mean, all this chaos we used to have is completely gone because everything is virtually done, and I'm getting 8 screws on my back table, I'm getting 2 rods, I'm getting the connecting pieces, and it's nicely laid out. And even if I have somebody on the back table who's maybe not as experienced as me, it's very straightforward to go through 8 or 10 implants and be done with it, as opposed to literally see thousands of things on the back table and have to pick during surgery the one that I would want. So it's a very different process. We're able to get the entire spine digitized and actually perform curve corrections, cut the bone, open up the spaces between the bones, and so on. And I'll show you a little example of that in a minute, but it's very, very advanced in its way to virtually see in 3 dimensions around the spine. And then we haven't even talked about the robot yet, right? This is just the enabling software. Here you can see a picture of all these slices that I can get done between the bones to identify the individual vertebral bodies. And if I have a large amount of bone here that I have to put this green screw through, it's easy, right? But sometimes in the thoracic spine, if we operate close to the space, sort of behind your heart, you have to imagine, there is usually no bony column at all to put that screw through. So if I have nothing to guide me, it purely depends on me to get in between the spinal cord, which runs here, and the aorta that pumps blood back and forth, around your body from your heart. The space here is no bigger than maybe ½ an inch, and I'm putting a quarter-inch screw in there. So it's very, very challenging. So that, again, takes so much stress from us during surgery to do that well, apart from the skill we need to have, right? That now is just as easy as putting a screw in a very large block of bone because the robot guides me predictably in there. So this is an excellent example of how this makes a difference for us. So it gives us much better 3D knowledge already by looking at the picture beforehand, and then the robot guides us in there with much less soft tissue destructions. And I don't have to go looking around the spine and expose it all with blood loss and so on. So the other advantage is we don't just look at one screw, right? We look at a whole bunch of screws. So if we put screws in a block of bone here, as you can see, the appropriate way, but we angle them a little differently. Imagine what it would look like if these screws are maybe in line or not in line altogether. Because if I have to place this red rod here, and one of my screws is off a little bit, it's much harder to place a straight rod in there than when the screw heads are all nicely aligned, right? This is just common like carpentry, basically. So if you have, any desire at home to make something, right, it's much easier if everything's nicely in line than that you have to sort of zigzag and snake a 2x4 through it. So it's a very similar concept, and the robot helps us to build those constructs much more predictably. Not so much important maybe for 2 or 3 screws, but if you have to put in 25 screws in a child with a deformity like this, I can tell you, this is very challenging if you don't have a guidance system, right? We used to do this all the time, 10, 12 hours of surgery, the poor child is asleep for that long, goes to the ICU, all that kind of stuff. And we had to come up with this in our brain during surgery. Now we virtually plan all of this, and then the robot just executes it from one to the next, to the next, to the next, and in the end we just drop the rod in there and we're done. So think about the impact of that compared to these sort of small cases that I showed you before. So I wanted to show you a quick video of how this actually works. So initially we had a tiny, tiny little robot. That's how we started. It sort of was the size of like a Coke can. You remember from the 80s, maybe you had these Coke cans that could sort of dance around, right? I see some people nodding here, right? You can still find them on eBay, I think. So that's what this initial robot sort of was like. And we attached some tubes through it and stuff, but it depended very much on us to do the right thing. But the software was capable of what I showed you already. Now we've built a robotic arm that actually looks like a robot and helps us to do that. So from here, we went to here, similar to that you decided from your past home to move into Trilogy for things because it's better, right? And it looks nicer and it smells better here too. But for all those reasons, we evolved, right? And that's why I wanted to show you. So what's new for spine surgery in Las Vegas at least, but also for Trilogy around the country? The robots are here. So again, this is the system we're talking about. This is the brains. This is the robot arm attached to the bed, and then we have a camera that allows us to see down onto the field just to follow our instruments. But I don't have to be distracted because I can look down where the robot is actually working. So you see the robot here attached to the bed. It sort of looks like Wall-E, right? You can see these 2 eyes here. So the robot goes and gets attached stable onto the bed and stable onto you as a patient. It's attached to your skeleton. And then the first thing we do, the robot arm sweeps over you as a patient because we want to make sure that the robot knows where you are on the table so it will never hit you. It'll always stay above where the patient is. So the patient is here underneath this drape, and the robot takes these pictures and creates what we call a finite element model. It sort of knows exactly where you are, and it knows it can work very efficiently above that space, but not inside of it. Then we point to the space generally where the spine needs to be, is going to be operated on. And then the robot still doesn't know where the spine is exactly, right? It only knows from the CT scan that I put these virtual screws in. So we take 2 fluoroscopy pictures as opposed to, say, 1,000 like before. So we get, this is again that C-arm, right? So we get a picture here while the robot is holding a special tool so it can identify relative to the arm, the robot, where the patient is. And we get a picture in one plane that we just did, and then the robot goes to the side and wants to get one more picture to also see from the side where you are. We want to have a 3D image, right? So you can only see 3D if you can look around it a little bit. So we had one picture already. Here we get our oblique picture is what we call that. And then these 2 images are allowing the robot to connect your spine in the operating room like this and like that, 90 degrees to it. It allows it to connect you to that CT scan that I virtually did your surgery on. And then we identify that is indeed, that matching process was indeed perfectly correctly done, because the individual pictures from the operating room and the CT scan are flashing back and forth. And then I can say, you know what, yes, this was a perfect match. And once we've created that, then we can start telling the robot where to go. So we look at the incisions one more time in the skin, making sure that everything's okay. And then I'm going to show you in 2 of those places to do some surgery here. So the robot arm is getting into position for me to place 2 of those screws. So we'll do one at a time. I put a little numbing medicine in there. This won't bleed, so you don't have to be too worried about this. So we put a little numbing medicine in the skin where the robot is pointing. Then I take my scalpel, my knife, right? Go straight down to the spine, since I know the robot will guide me always perfectly in the right position. Then we put a little dilator in there that has a little tube around it. So the tube you can see here stays behind. Then I put a drill guide in there that has some spikes that actually holds on to the bone. I tap that very gently in there and hold on to it a little bit so the spine doesn't move underneath my tool. And then I take a drill and I drill a 3 millimeter hole, 30 millimeters deep. So it's a little over 1 inch deep. That's my starting hole through that column of bone. I pull that out, then I put basically the same size, but it's hollow, a little tube in there, and that tube can accept my wire. So this is the same as the wires we saw earlier, right? But this is robotically done. This used to take everybody, 10 to 15 minutes or so per hole. This took us 40 seconds, right? And now we do it one more time. So I made my hole already with my knife. I take again what we call the trocar, this little spike tool, to go down to the spine. We put our soft tissue guide in there. Then we take our drill guide, I put it down onto bone, and I'm still sort of, utilizing tactile feedback to make sure that everything is okay. I drill that in there for 30 millimeters again, so just to get it started. Then take that skinny tube that allows my guide wire to go through. And while I'm pulling that out, the robot already goes to the next level. I put my wire in there. And, this took about, I don't know, 1.5 minutes or something. So we do this with every level. So no big skin incisions, and we're still capable of sliding the screws straight down. We get a verification picture before I confirm putting in the screws, and you can see all the wires are indeed in the right place. And then we can put the screws right over it, very smooth, very quick, without creating a lot of incisions and blood loss and all those kinds of things. So we did 2 pedicles, again, used to take somewhere between 20 and 30 minutes, right? Because it takes about 10 to 15 minutes each. And when I did this, we did about 7,500 screws already. We put screws in the pelvis and so on, and never missed any of those trajectories because the robot every single time was perfect. Now, a fool with a tool is still a fool, right? So this doesn't mean that the robots can do something inappropriate if you force them a certain way, if you work against them, if you place the screws incorrectly during the virtual planning. But generally speaking, the success rate of this is absolutely incredible. So That's the robot. Now, why do we use robots and why do we use this hardware, right? So for the next 20 minutes, I'll talk to you about that. I wanna make sure we end with something you can actually say, hey, you know what, I learned something this afternoon, instead of that I just saw cool technology that I hope I'll never need. So if you think about the cone of economy, if you had an ice cream store, right? This is your cone of economy, right? Now, we're not selling ice cream this afternoon. We're doing spine surgery. So as a spine surgeon, this is our, what we call, cone of economy. This is the space in which it is economical, simple, straightforward to stand up straight. And this is not exactly a cone, it's like an oval. But in this space here, it is comfortable to stand and walk up straight without utilizing additional energy, because otherwise you would topple over, right? If you lean too far forward, you have to use your muscles to prevent you from not continuing to go. You have to use a cane, you have to use a shopping cart, any of those things, right? So in this space here, it takes very little energy to be nice and upright because everything is well balanced. It's like when you hold a hammer on its head, basically, you walk around with it. As long as it's nice and upright, you're golden. So this, as I said earlier, is not a circle, it's an oval actually, because we have 2 feet, right? So I know my feet are not on the video, but my feet allow me to have a little bit more stability from left to right, because I have 2 feet, right? I can put pressure on one versus the other a little bit. But more importantly, the oval is very small from front to back, because as soon as I start to lean forward a little bit, you can't compensate with your feet. You have to use something else. And those are your muscles, as well as the angle that your knees and your hips take to hold your body upright, and then sometimes assisted devices like, rollators and shopping carts and so on. So what is very important, if you forget everything else that we just talked about, the outcome of a spinal reconstruction, like things with rods and screws, right, is directly related to your ability to stand up straight after surgery. So if I don't correct your angles right, you will never be as good as when I do a perfect job correcting every angle that your spine needs to have relative to your degenerated hips and knees and so on. So as a spine surgeon, we have to think much more than just L4-5 or L5-S1, right? The junction from your spine to your pelvis. Because if we mess it up over there, you'll have a lifelong misery going forward because you can't correct yourself effortlessly to stand up straight. So it's very important, even if you're a young person, you undergo surgery with rods and screws and so on for whatever reason, that the angles we put your spine into are perfect. Because if they're not perfect, if the first time you get into a house and the door is not right because the hinges are off, that's never going to get better, right? Unless you fix that. So I do a lot of revision surgery because of that. And this is what we talked about. Classically, you see this shopping cart phenomenon, right? Go to the Walmart, the Target, wherever you want to be. Lots of people, they slug around like this because they can't stand up straight to save their life. And why is that? Their spine is degenerated. They've lost the ability to stand up straight. Their hips are stiff. They can't really compensate through it. And their plumb line, meaning the junction from your neck and your thoracic spine, if you drop a line from that, doesn't go through their back and buttock area anymore, but it's forward. So as soon as that's forward, you have to use compensatory mechanisms to stand up straight. So a shopping cart or a cane is one thing. What a lot of people do, so this lady is already on a cane, right? But they cheat a little bit because their spine is so straight and has lost all ability to stand up straight with their, what we call lordosis, right? That she also starts to bend her knees. Her plumb line is forward, and by bending her knees, initially, say she was like this with straight legs, but by bending her knees, she can sort of cheat and bring her spine up a little bit. But this is terrible for your quads. It's terrible for your knees because there's all this muscle force from your quadriceps over your kneecap. So if you have some arthritis already, this won't make you walk anymore, right? The only way to do it is actually to lean on something. But who wants to have a rollator, right? Nobody wants to look old. So unfortunately, people become sedentary, they gain more weight, the problem only worsens, and that's where you go. So bad problem. So remember this picture, this is her straight spine. She has no what we call lordosis, and we're gonna correct this with the robot in a minute. And sometimes I see people like this. She had like 7 spine surgeries, can't stand up straight to save her life, can only look down at her shoes. You can see the hardware actually sticking out of her back here. So we're going to talk about this case a little bit later too. So these are the more extreme cases, right? So again, if you can't stand up straight, your quality of life is much worse than the person who can. And I want you so badly to understand it that I always show this video with this. So your ability to stand up straight also depends on your brain, right? So if your brain is a little bit off, maybe because of drinking a couple hours earlier, you also can't stand up straight and you have to use compensatory mechanisms. So this man got pulled over. He's being asked to provide his driver's license, so he's sort of fumbling around with it, right? His coordination is not so great. You'll see that his driver's license falls on the floor there. So he tries to pick it up, but he is not well coordinated, we just decided, right? So he smacks into the wall in front because he was not capable of initiating his compensatory mechanism. Now he's a little bit sobered up, so now he's using his compensatory mechanism. But that's also off because he hits the door over there, right? So if you remember nothing else, it's important to stand up straight. It's important not to drink too much. But if you can't stand up straight, these compensatory mechanisms are challenging for us. And if there's anything that prevents you from using it, you're not going to do as well in life. So you remember this picture from that lady who was sort of cheating with her knees, right? She has no normal, what we call lordosis in her back. She has a flat back deformity. And this is what that picture looks like on my robotic system. So I have virtually placed these screws, but I know that if I fix her like this, I do her a tremendous disservice because I'm not getting her upright. So I need to do this to her. And I can actually plan this with the robot. So I'm putting all my data in the robot, and then the robotic program will tell us, you know what? You need 48 degrees of additional curvature in that back to make this woman successful. Because I don't have it here, but I can see exactly where her neck begins and her thoracic spine ends and so on. So based on where she needs to be in space, I know I need to reconstruct this. So I do this operation on her. It's a front, back, yada, yada, all kinds of stuff. Doesn't matter. I need to recreate this. And if I overlay my X-ray picture in the operating room, you can see that based on my plan here, I executed this operation by putting cages in between the bones of her back and recreate exactly the curvature that she needed before I flipped her over and put the screws in with the robot. So the robot is much more than just this guidance tool. It helps me to know when you leave the operating room with me, you're going to stand up straight. You're going to stand up exactly where you're supposed to be because I planned that the evening, the week before, what have you. And I don't have any surprises the morning after surgery when you get out of bed for the first time. And I suddenly see, oh, well, I guess we would have liked 10 more degrees, but I guess maybe next time, hopefully she'll do well. I mean, that's not excusable anymore because we have planning procedures here in the robotic system that allows me to know exactly what I need to do during surgery. And this is just a 3-level case, but imagine doing these kinds of cases in old, sick people, right? The robot helps here even more so to make this a lot more predictable and make the execution not as hard, even for people that are maybe somewhat challenged in achieving this before. Because this looks kind of daunting, right, with all these wires and stuff. And then once you have the screws and you have to pass a rod like this underneath the skin, those are additional skills we now need to teach our friends. But at least we know where we need to go to get people predictably upright, even if it's like, one of these kinds of operations. So this automation type thing I wanted to share with you real quick in 2 cases. So this is a 68-year-old gentleman. He had 6 prior surgeries. He had dural tears, meaning spinal fluid leaks and all kinds of stuff. At some point, he ended up with a decompression of his spine. So they took all of the elements in the back off for good reason, because he had a lot of sciatica and so on. And then he had a single level fusion because they cracked a part of his bone that was important to stabilize him. So they put these screws in there, but he had recurrent leg pain. And most importantly, he could not stand up straight. So he had what we call sagittal imbalance. That's imbalance from the side. And here he is standing up. So maybe this looks sort of okay, and this is all fine, and the screws are in the right place. His ability to stand up straight is, of course, significantly compromised because we talked about this plumb line before, right? It's way forward. The plumb line needs to run about here because that means you're in our cone of economy in the right place. So this is a problem for him. He gets an MRI scan. He has various problems. But as you can see, he has a little bit of a restoration of this curve, which is good for me because that means that not all of his spine is fused together, but he's collapsing through parts of his spine between the bones, these discs, right? That when he lays down, these discs open up a little bit, and when he stands up straight, they collapse forward, because he has no muscle in the back anymore from all of his prior surgeries because he had one of these like salad bowl type incisions, right? So there's no live muscle anymore that can help him stand up straight. So we plan this operation, and I do basically what I just showed you with that shorter operation. I fill the spaces between the bones with a variety of cages. We make a small incision in the flank and put 2 cages here at the top. That's what these are. They're 3D printed, very cool titanium material, not important for now. And then in the front, we put these 2 cages by a small incision right underneath the belly button. So we operate around the spine. We don't make these like shark bite incisions anymore. We make a small one, maybe 1.5 inches on the side and 1.5 inches in the front. And we're capable of reconstructing the angles that this patient needs. He walks within 5 hours from surgery. 100% of my patients walk within 5 hours from surgery throughout the last 6 years or so, because it's better for you. Motion is lotion, and even over at Southern Hills already, they had what we call an early mobility program. So what I need fits exactly in what they were offering already. So this is a very good partnership because they understand how important it is for my patients to get on their feet. So say I did that surgery on a Wednesday, now it's Thursday, I got the patient up and walking with physical therapy. And I'm getting a CAT scan, and you can see here that there is absolutely nothing in the back of this gentleman, right, from all of his prior surgery, so there's nothing to hold him up either, hence that he was collapsing. But you can see now that he has a nicely restored what we call lordosis. You can see his cages in there around the area where he had prior surgery. I planned my surgery with all of these screws and stuff, and this looks kind of chaotic, but for me and my brain, this is very easy because it's one level at a time. And then once you superimpose it all, it looks kind of like much, but it's really not that significantly different than doing a 1 or a 2 level operation. I'm looking at my skin incisions. I can plan and sometimes cluster these things a little bit to make it look a little prettier. And then I do my surgery. So in the past, this would have been an incision from here to here. You can see his old incision here that they did before, but you can see I just have a couple poke holes with a couple towers in there that are not more than half an inch in diameter. I'm firing some screws across the spinal canal to hold on to his pelvis, since I did so much correction that we actually want to have good fixation at the bottom of the spine. There's a picture from the top. You see the robot friend attached to the spine over there. And then these are his final pictures. So here he's standing up the day after surgery. So the first day was Wednesday. Thursday, he walked around with physical therapy. Friday, we did the second operation, and I had examined him, and all his weakness was gone. He had no leg pain anymore. And most importantly, apart from how cool this is, you now know how keen I am on these kinds of views, because I need to know from the side that I have reproduced the lordosis, this angle that this patient needs to stand up straight. And that's where he came from, and this is what he is right now. You remember that plumb line thing we talked about from earlier, and now you see his plumb line go perfectly through this. And this is not just a mystery anymore after I'm done with surgery, if I've done the right thing, because I've planned this carefully out with the robotic system, and then the robot helped me to do part of it, but it's still the planning that helps us to make these people successful right out of the gate. So you remember this lady? Inability to stand up straight at all, right? So this is her. And again, I want to point you to like the hardware that's sitting right here, that when she stands like this, is like pointing through it. So very complex deformity. Again, same thing. This is just a picture of one of these planning type things. I made this here through a very small incision in the flank also. This is the way that we approach the spine nowadays. So I put these cages in there and basically restacked her entire spine. You can see the cages there, and because she was so unstable, we put some little plates in there just to hold on to things. Then I plan her case, and you saw this earlier already, right? In 3D, I can walk around this. So this is where she came from. And now with a lot of complexity, eventually she gets an operation like this for a variety of reasons. We put some additional rods around there of a softer material. So it looks like there's a lot of hardware, but it's actually a different material that allows for her biomechanics and her bone quality with osteoporosis to be a little bit better matched together. So the details here don't necessarily matter. The details here are that she's nice and upright, and that she can now stand up straight from completely unable, right, other than with a walker to walk a couple steps to get upright. And this is where she is a month out from surgery, and she's standing up next to me in clinic, and just the family can believe it, and so on, right? So this is, I was trained well to do this, but then again, robotic guidance and the enabling part before surgery helps me to be more successful. And here's where rubber hits the road. This is 2.5 years of data, because I don't have new data from CMS yet, because 2020 was kind of a weird year, right? So this is until the later part of 2019, coming out of the beginning of 2017. So on average, more than 3-level surgery is like deformity type surgery, right? That's how they sort of group this together. So on average, we do 125, 126 cases every 6 months. So I do about 250 deformities per year, and another 250 like, discectomies and cervical type spine surgery and those kinds of things. So these are the cases, and this is the average length of stay for these people. And you see 2 lines here. The blue line over at 4 days is the expected length of stay. This is based on the same codes that we put in, right? And this is the national data. So nationally, people stay for this for 4 days. My data here in orange is 2 days. So my length of stay is 50% less than the national average for the same type surgery, right? CMS, the Medicare, takes care of all this stuff. And then if you look at complications, the blue line for exactly the same surgery, looking at all these other things that are complications after spine surgery, average 16%, pretty decent compared to what we had before. My complication rate is 1.6. So this is objective data, right? I didn't cook this up. This comes from the hospital, from CMS. You can find this online and so on. And then the readmission data, this is what gets counted against us, right? And hospital CEOs are very concerned about this because they got to pay for this. So the national average readmission rate is about 4.7% for these types of surgeries. So 1 out of every 20 patients gets readmitted. And my number is 0.8%, so 1 out of 100. So significantly different, and not, everybody thinks they're the best surgeon in the world, right? I don't think that. But I think the enabling technology that I can use to my advantage provides me objectively with doing the right thing for my patients and what looks like, better than a lot of other people out there. So I think there's objective, again, evidence that it's not just cool and sexy what we do, but it actually helps us to provide better care to our patients. Now, how cool would it be if we had truly like X-ray vision, right? And we could get rid of this camera and, all these other things that we still use. So that's what we're developing now. So this is a headset that actually has retina projection of the spine underneath the skin directly onto my eyes. So you can see me working here. We work with these, initial fairly crude tools because we just have to get this working, right? But what you see down here is what I'm seeing on my eyes, in my eyes as I look down onto my patient. You can actually see a 3D representation of the spine, and the tool I'm holding that I'm getting into the pedicle with, which is, not a cool drill and all kinds of things just yet. It's called a Jamshidi needle, so it's kind of a stiff needle that we go into the bone with. But this is what I'm seeing looking straight down onto the patient. So we connect this to robotic technology. I never have to look away anymore, and I can look straight down and in 3D see what's going on. And the good news is this is called Augmetics X Vision. So just remember X Vision. We just got that, and we got certified to start using it next week over at Southern Hills also. So there's no hospital in Vegas who has both technologies available to our benefit. Again, not so much to be cooler and sexier than everybody else, but by evidence show that we provide better care to our patients. And I can't wait to start using this clinically. So advantages, last slide, navigation and robotics. What is the issue? We are safer, for sure, right? We don't put screws in the wrong place anymore. We have greater accuracy that's now reproducible, one after the next, Monday morning to 7 a.m. to Friday night, 7 p.m. We have proven reduced complication rate, proven reduced radiation compared to before. We are more efficient in the operating room. We do much better for our systems as a whole, right? With reduction of readmissions and faster OR times and so on. And most importantly for you as a patient, we are doing much better than we did 15, maybe even 20 years ago. And I think embracing and collaborating, utilizing sort of this technology for minimally invasive spine surgery will redefine the standards of how spine surgery are supposed to be done. Very different than how a lot of people are currently doing their surgeries, obviously. And I'm proud to say that we're front runners here together with Southern Hills Hospital. I would love for you to come see us in clinic should you need some help, or check it out at least on the web and look at some of these websites that are available that show some of our videos and some of our work. And I'm always happy to talk to you, of course. So come visit us at the Robotics Spine Institute of Las Vegas, or come to Southern Hills, and I'm happy to see you there. So thanks again for having me. It was wonderful. Hopefully we have some questions. Yeah, oh, we have some questions. Okay, very good. I appreciate it. But thanks for the opportunity to be here.
Absolutely. So we have Russ from North Carolina, and he says that he has ankylosing spondylitis, and my neck is almost fused. Is there any way to restore motion in my neck?
That depends a lot, Mr. Russ from North Carolina. Ankylosing spondylitis is a genetic thing, right? So usually some medicinal help can reduce the speed by which things are ossifying or becoming stiff. Sometimes if the joints in the neck are still relatively spared and you just bridge the front part of the spine around the disc, what we can do is sometimes chisel that bone away and put a disc replacement in there. But it has to do with a little bit of how speedy your disease has progressed, as well as what it looks like in the rest of your spine. Because sometimes we do these surgeries and then literally 6 months later, your spine has walled off our articulating device that gave you motion, and you're just as stiff as you were from the beginning. So every case stands on its own with this. It's an excellent question, and it's a tough diagnosis to bear. But there are certainly options to look at it. So if there's an opportunity to find somebody locally there, or I can be a conduit to someone, one of my friends in North Carolina, or if you want to come to beautiful Vegas and come see me, I'm happy to look at your case specifically and see what we can do. Thank you.
We have Jacqueline. She says, I had lumbar laminectomy 20 years ago. I was fine for 10 years, but now I have chronic pain and mobility limitations. Surgeon told me that second surgery had less than 10% chance of success due to scar tissue. Is robotic surgery any different?
It depends a little bit. Before, when we used to do revision surgery, we went in through the same incision. We had to dig through all the scar, find your nerves, cut the scar tissue off the nerves, and so on. So what we do now is what I'd like to call indirect decompression surgery. So in case that you may have new scar that has formed onto the nerves and makes things really tight and gives you the pain, if we think that's your pain generator, what we can do is reconstruct your spine around it and basically ignore all the scar and elevate the space that the nerves have to travel through and relieve a lot of pain that way. Every case, again, is sort of unique, like I just said earlier, but robotics helps us to think differently about surgery nowadays, since we operate around the spine as opposed to through the old scar bed to it. So the likelihood that it's more successful that way with less toxic side effects to you is quite a bit greater.
One more. And we have Susan that asked, I have advanced lumbar spondylosis
Yeah.
with multiple levels of central lateral recess and foraminal stenosis resulting in potential neural impingement. I just had a cortisone injection, but with minimal outcome. Is there anything else that can be done?
Well, it sounds like that you were reading up your MRI report with spondylosis, which means arthritic disease of the spine, right? And that you have some stenosis, meaning some tightness problems around parts of the nerves in the center of the canal, as well as towards the outside. It's called the lateral recess stenosis. If it's indeed quite significant and cortisone shots and so on are not working, if the compression is bad enough, imagine if I take my finger and I squeeze it pretty hard, there is no magical chiropractor, physical therapy injections that make mechanical pressure better. So should you have that as a true problem, and we agree on that in the MRI scan, well then great. Then we get the pressure off the nerves and make sure you are not unstable and close things back up through little poke holes. Or if it turns out that your spine has some instability, which is very common in spondylosis, right? You have a little bit of a slippage of your spine that starts to roll those tight nerves back and forth as a reason why the cortisone doesn't work. Then we sometimes also stabilize the spine and make sure that your nerves can go through without a problem. So I'd love to see it, because it looks like that it sounds like that there is some additional help that you would need. And I think there's some good options that we can discuss. Okay. Well, yeah, we'll start in the front here. I think we have a couple questions here.
She was saying spondylosis. Is that a difference between spondylolisthesis and spondylosis?
Yeah, so let me clarify that. I don't have a board here to write on, right? But spondylosis means arthritis of the spine. Then you have spondylolysis, which is a crack in part of the spine that prevents the spine, the bony skeleton, to stay stable. So you have a chance for a bit of a slip of your spine. And that slip is actually called spondylolisthesis. Listhesis means slippage. Spondylo means spine, so slippage of your spine. Spondylolisthesis, spondylolysis, lysis means crack, and then spondylosis is just arthritis.
And is there a delay in now because of COVID and getting an appointment and coming to see you?
That's a good question, actually. We have been very good about creating like a COVID-free, if you will, environment. So there is no additional delay. We have our office set up, but there is excellent spacing, excellent distancing. Everybody's very aggressive about wearing masks and washing hands and using sanitizer between patients, sanitizing the rooms in between patients. So we've spread out our appointments, obviously, but there should not be any issues with getting access to us.
What's the best place to make an appointment with you?
Okay, she just asked the best, I'll repeat her because you have no microphone. The best place to make an appointment, I would call our phone number. I'm sort of standing in front of it. Just call this number. We have multiple locations throughout the greater Las Vegas area, and we're always happy to help in any of these locations. So I would just invite you to call, and we'll make sure we get you in and sit down and explain to you what we can do. You're welcome. Yes, sir.
Doc, you were talking about slippage of the spine. So if you correct that, are you technically fusing it? Okay.
Good. That's a great question. Yeah. So
What
there's
happens to the other discs around it?
great question. So and this could be like a talk for an hour in itself, right? So if somebody has indeed slippage or deformity or tumor or trauma, there's like 4 reasons why we put rods and screws in. And you saw some deformity problems and so on. But say you need a reconstruction of your spine. If we reconstruct you, we put cages in there and put things together with rods and screws, you technically have a fusion. But a fusion is just putting 2 bones together where they used to sit without doing anything about it. So yes, it is a fusion, but it's more of a reconstruction, redialing your spine where it needs to go. And then, of course, since you take a motion segment away, the fear is always that you transfer the stresses from that segment that can't move now to the next levels. If you carefully look at the data, though, if you have a perfectly normal spine and you fuse that level, right, because if there's no slippage or nothing, then you indeed take a true motion segment away out of this chain. But you have to imagine, we're not operating on normal levels, right? We're operating on levels that are already slipped, that are already degenerated, that if you very carefully look, have only, if any, pathologic motion. And if you have a spine that sort of wavers around like this, the stresses on the adjacent segment to make up for a broken chain are actually just as high as when you put that broken link back in the normal position and then fuse it together. Because then that segment above can anticipate on the motion that it is requiring to do without constantly having a foundation that moves all over the place. So if you do nothing to an unstable segment, your adjacent segments will also accelerate its degeneration compared to if you have a completely normal spine. And it's not any faster if we reconstruct the spine in that new position. So technically, yes, there is a different transfer of forces to the next level, but it doesn't clinically cause you to need more surgery just because we put rods and screws in. If it was done for the right reason, by taking away instability or motion or tumor or trauma, then the accelerated adjacent segment degeneration is negligible. Does that make sense? Yeah, so it's a complex answer, and we have whole meetings about this, right? What do we do about this? And then people say, well, why don't you put a disc replacement in? Well, disc replacements only work if you have a stable segment. But a stable segment is usually not the cause of a lot of pain, unless there's just, a bad disc or something else going on. So disc replacements in the lumbar spine have historically not proven to be all that successful, but stabilizing procedures have been. And a great example is, Tiger Woods, right? That he had multiple decompression procedures. They tried not to fuse him, right? And then that level that they operated on was unstable. So the decompression procedures alone did not work. But as soon as they stabilized them, from what I remember, he won the Masters, right? So that doesn't mean that if you have a spinal fusion, you can't play golf at a extremely high professional level. And his adjacent segment, because I know the surgeon who operated on him, his adjacent segments look fantastic, and it's been now 3 years or so, I think. So, and there's no difference on the MRI scan whatsoever. So, but it's a good question, and we always weigh, of course, pros and cons, short, medium, long term, if we do something. But I hope that you understand the cases we operate on. They have, excellent indications for needing what we do. Otherwise, if I wouldn't operate on my mom for something, I wouldn't operate on you for something, right? That's sort of my guide, I think, throughout my professional career.
What other hospital sponsors this type of robotic spine?
Well, it's not sponsored per se, but I guess subscribe to, hey, robotics are important. In this area, in the entire city of Las Vegas, we are the only hospital that has a Mazor X Stealth Edition robot with the Augmetics system. So there's only one hospital in the entire 2.6 million people or so here. And I know that in the next best town over is Reno. They have an Augmetics system, but I don't think they utilize the robot. Yeah. So that's interesting. So there's a lot of university hospitals that have robots, but they're somewhat reticent to use it because it's hard for the professor to learn it because the professor is supposed to know it already. So there's a lot of hospitals at university levels that want robotics and want to be really good at it and have like signs up all over the place, but a robot stands in the corner and collects a lot of dust because the humility necessary to learn this, that's sometimes a little bit of an uphill battle. That's a very interesting question. Yeah, it is. Yes, ma'am. We have one more question? Okay, real quick. Yeah.
I've been told for the, I don't say it the right way, but a combination of issues, including the spondylolisthesis, you say it so much better,
That's okay.
that there would be like a 4-month recovery with a back brace afterwards for this combination of surgeries that's been recommended for me.
Okay.
Is that what generally?
Well, it depends on, until you play 2 matches of singles tennis, it would be about a 4 to 5 months recovery. But if we talk about, I want to go by myself back to the grocery store and all this kind of stuff, that's like a 2-3 week window. And you might not be, fully recovered at that point and allowed to do bending, lifting, twisting, and all that to your desire. But it's a very functional recovery. Again, I can't overstate, motion is lotion. We say that all the time, not because it's funny, but it really makes a big difference that if you get off the couch right away, and after surgery, every half hour to 45 minutes, I want you to go to the bathroom, to the kitchen, get a glass of water, be up and around, and after 2 weeks, have a walking program outside. We all guide that, right? You'll be very, very good by about 6 weeks out from surgery. I can't make people perfect, right, with none of this stuff. But we try really hard to do a good operation and help you in your rehab to be sooner rather than later up and around. You're welcome. Yeah.
Are Mazor X Stealth treatments covered by insurance, or is this still considered experimental?
Yeah, that's a good question. Ever since the beginning, right, as soon as we came out of the lab, the Mazor systems were FDA approved, right? We never utilized non-FDA approved equipment, tools, or what have you. But then the processes to make the robot work with us, to make it better and better, that has continued to develop throughout this process, during which they were FDA approved already. So robotic guided surgeries are absolutely approved. The funny thing is we don't get paid anymore to do any of this. I don't get paid to plan your surgeries beforehand and think about this and brainstorm the week before with my team and all that kind of stuff. There's no additional income for surgeons or hospitals. It is purely cost that eventually, over time has to be taken into account. Because I don't make any more money doing it robotically versus not robotically, but I think I do a better job for you. And if I do a better job for you, you'll tell your neighbors, and then hopefully I'll have more patients and so on. So in the end, of course, yes, it is better for us to do a better job for you because we'll have more patients, but it's not like on an N-is-1 basis we get paid for it. So you don't have to worry that a robotically guided procedure is suddenly going to cost you a lot more because it's the same price as if we would not use the robot. Medicare doesn't award us for developing and utilizing technology to make care better. If anything, they punish us for it. So don't worry about that. Very good. Well then, thanks very much for your attention. I hope you have a wonderful week until Christmas and New Year's. Happy holidays, and hopefully a very healthy and safe 2021. So hopefully I'll be back. Thank you.